Hi guys, and welcome to this video on initiating ventilation. In this video we'll be looking at the ventilation journey the patient embarks on. We'll be examining some of the factors that determine the start settings, and at the end there's a brief simulation using the V500 Infinity Ventilator simulator. So before we start to ventilate anyone, there's some essential information that you need to take into account. The first of these things is the type of ventilatory mode we'll be trying to employ. We'll be looking at the patient journey from intubation to extubation, and we'll have a brief look at the types of lung that we are attempting to ventilate. So based on how the breath is generated in the first place, so how inspiration is generated in the first place, there are three types of modes. Firstly, there's a control mode, and in the control mode the ventilator is saying, I am going to ventilate you. You may wish to join in, that's your business. You may wish to take a breath, you won't be able to. I'm in complete control. So these are the control modes, and they're the modes that ventilation started with, but since then thankfully we've moved on a fair bit, because these modes do not lend themselves very much to patient synchrony. For patient synchrony we've moved on to the synchronized modes, and in those modes effectively the ventilator is saying, I am going to ventilate you. However, should you wish to join in, I'm sure we can come to some sort of arrangement. And there are various different sorts of arrangements. Some have advantages over others, and these modes form the bulk of ventilation practice in the modern day. And last of all, there are spontaneous modes, and in the spontaneous modes the patient generates inspiration, but sometimes ask for a bit of a hand from the ventilator. And these are the modes you are hoping to get to prior to extubating the patient. Now it's important to remember that all these modes can be either pressure or volume cycled, and although there are limitations on some of these modes, you can actually ventilate any patient in any mode, provided you know what you're doing. Right, so there's a patient journey from intubation to extubation and everything in between. And to complete that journey, we need to consider two things which make it possible. So for anything in life, you need brains and you need brawn. The brains of the system obviously is the breathing control system. And when you're spontaneously ventilating, that's intact. There's no point it being intact without having some muscle to actually affect what it is you want. So in other words, in this time we want a decent tidal volume and a decent rate. So the breathing system control tells you how many breaths you want, and the muscles just get the job done. When you're spontaneously breathing, this is working very well. Now, if you need to be ventilated for any reason whatsoever, those things are taken from you. So they're either taken from you by illness, or they're taken from you by the fact that you need to be intubated in the first place, and the sedation and muscle relaxation rob you of both your breathing control system and the muscle to get the job done. So patients like this can have controlled ventilation. So one of the control modes we mentioned earlier. And the reason this will work well is because the patient needs a governor. He needs something to tell him when to breathe and how much, and that's what the control modes are. As time goes by, however, the patient actually starts to recover, so the control system comes back first to some sort of degree, and the muscles actually can join in, but usually they're not optimal at this stage. So for these patients, they need mixed ventilation or synchronous ventilation. In other words, the patient knows when he wants some of the breaths, but is not quite sure of all of them, and he isn't actually strong enough to generate the right sort of tidal volume. So in these sorts of patients, the synchronous modes work well, and that's why the synchronous modes make up the bulk of what we do with the ventilator on the intensive care unit. As the patient improves and starts to lighten up from his drug-induced or illness-induced sleep or stupor, what you'll find is that the patient then can decide when he wants to breathe for himself. And because of that, he will then be switched to some sort of spontaneous mode. Now, because he's not all there all the time, the spontaneous modes also offer help, certainly with pressure support to make sure that the right sort of tidal volumes are available, but also assisting if the patient sometimes forgets to breathe. And then once he's completed this part of his journey, it's probably time for the patient to be extubated to go to pure spontaneous breathing on his own. So that is the patient journey on the intensive care unit. But it doesn't tell the whole story, because the other thing that we need to consider is the interaction between the ventilator and the lung itself. So there are three types of lung. There's the normal lung, the small and white lung, and the large and black lung. So normal lungs are exactly that. So they're normal. So when you actually start ventilating them, the sophistication of modern day ventilators will actually tell you what they think you should be ventilating this lung at, provided you put the appropriate patient category in and that patient's weight. Small and white lungs are what you get with diffuse alveolar disease, such as ARDS, and pulmonary edema and the like, and these conditions require a higher mean airway pressure to maintain oxygenation. The large and black lungs, these usually have some sort of airway obstruction, so for our practice, asthma and or bronchiolitis, and you need to pay a lot more attention to time. So how long is the I time, how long is the expiratory time, what's the respiratory rate, and you need to manipulate these to maximize expiratory time. Now, all this said and done, we need to remember that the lungs need protecting from the ventilator. So ventilators are wonderful machines, but they are capable of injuring the lungs. So we want to minimize the amount of pressures and volumes that we use to get normal gas exchange. So the aim for all this ventilation is actually to get acceptable gas exchange, but not at the cost of high pressure or high volume ventilation. So what we're trying to do is get that acceptable gas exchange without the peak inspiratory pressure going higher than 30, and also trying to keep tidal volumes within a certain limit. So for normal lungs, 5 to 8 mils per kilo. For small white lungs, 5 to 7 mils per kilo. Some people would say less, so I've heard 3 to 6 mils per kilo being quoted. And for large black lungs, you can use larger tidal volumes of 7 to 12 mils per kilo. However, you'd expect to use a slower rate. So with that in mind, your next decision is, do I want to set pressure or set volume? And honestly, that's not really as important as you think. Sometimes it is, but the vast majority of the time it doesn't actually matter that much. The things to remember is that if you are setting pressure, it's important to know that it's the mean airway pressure that's actually driving oxygenation. So when you set pressure, you're guaranteeing some sort of mean airway pressure, but that guarantee comes at a tidal volume and a minute volume that may vary. Conversely, if you set volume, you're guaranteeing that volume, and you're guaranteeing ventilation, but that guarantee comes at the expense of your peak inspiratory pressure and your mean airway pressure varying. So therefore, what you need to do is, if you do set pressure, you need to check the volumes that are being generated, and if you set volume, you need to check the pressures that are being generated. And if you can do these things, then actually get off to a reasonable start. There are many other factors, obviously, that that determine the initial settings or what you would start at. And they would include all of the following, but this list is not exhaustive. So the important thing is, one of the most important things is how are they currently being ventilated. So patients don't just magically appear on the intensive care unit. They're usually intubated either in accident and emergency, or they come from operating theatres ventilated, or they're brought in by a retrieval team. So these teams that have been looking after the patient before they got to us will have information that's useful for us. They'll have information about the intubation, whether it was difficult or not, whether he's been intubated before or not, and if he's been ventilated before, was how easy or difficult was that. They'll also tell you how the patient's ventilating now. They'll tell you what their settings are. And there's no reason why you can't start with those settings, but the thing to remember is these patients will either be handbagged up to the unit or will be on a transport ventilator, and the ventilators on the unit are nicer and better at ventilating patients than the transport vents are. And as such, the settings that they come on with on the transport vent, usually you can lower those when you go onto the conventional ventilator. So be good practice to start with what the preceding team were using, but expect to lower them quite quickly. Pre-existing conditions play a large part of how you would start to ventilate a patient. The classic things in paediatrics which affect us are things like chronic lung disease and neurological disorders, and things like kyphoscoliosis and the restrictive component that puts on ventilation. So for someone who may have normal lungs, or for whatever lung type they have, if they've got these pre-existing conditions, those conditions are going to change the way that you approach it. The current lung type obviously is important, so whether it's normal lungs, small and white lung, large and black lung, that will determine how you decide to set the ventilator up in the first place, and we've talked about that already. And obviously the height and or ideal body weight of the patient will also determine how much ventilation they get, because obviously we're going to try and set up tidal volumes in mils per kilo, whether you use pressure or volume. You also need to consider, is there a ventilatory strategy you're going to use for this current patient or for this current disease disorder? So a casing point would be someone with a neurological disorder, and you wanted to do some neuroprotection. So those patients, there's a strategy where you're going to try and keep carbon dioxide within a certain level. So that will obviously impact on your initial setting. So you might, for instance, pick volume over pressure, and you might want to guarantee that volume. And that would then change what you would have done if you weren't trying to do this. So strategy is important. Then the other thing that sometimes we forget is, what do we expect from the patient? So are we expecting the patient to contribute? So normally on admission, usually not, but that could change rapidly. So is this a child we're trying to wake up quickly? And if so, therefore we wouldn't go to a control mode, which you could theoretically use, because you're going to want him to wake up, and when he wakes up he can just go straight into his synchronous mode. And also, last but not at all least, what is the unit ventilatory experience or policy? So some units only use this mode, other units only use that mode. I kind of like using not more than 3 or 4 modes, so things like BiPAP, SIMV with Autoflow, and some form of pressure support would be the things that I would stick to, and that have worked well for me in the past. Now let's look at a little clinical example. So let's look at a normally fit and well 3-month-old 5-kilo baby who was born at term. So he's been admitted from theatre post-laparotomy for intestinal obstruction. He's well sedated, muscle relaxed. So now what I would like you to do is to decide how you would set up his ventilator on PICU. So a good thing to do would be to look at the things or the factors that influence how you would start ventilation. Work out in your mind how you would commence ventilation with this sort of patient, and once you've made up your mind, get back into the video and see how I would do it. Right, so stop the recording now. So my thought process would be, one, to find out the current intubation and ventilation information and decide if I was going to accept that or move forward. The child has no chronic lung disease or no other chronic concerns, so I think that helps me. I would think that the child should have normal lungs because he hasn't got lung disease. However, he's had intestinal obstruction. That usually comes with some sort of loss of fluid into the abdomen, and he might have been third spacing, and he might have had a lot of fluid resuscitation. So those sorts of children, although you think they've got normal lungs, they're perhaps small to white lungs. So you would start ventilating and then see exactly what gives. So you look at what's your oxygenation, what's your end tidal doing before you then get a gas. You see what tidal volumes are being generated on the ventilator or what pressures are being generated, depending on whether you started volume or pressure mode. Then you need to look at the body weight. So this is a 5 kilo child. So 5 kilo children can either be ventilated in neonatal mode or in pediatric mode. There's no real advantage to one over the other. However, if you ventilate in neonatal mode, you need to remember to put in the near flow sensor, because that will then help tell us when the patient's asking for a breath. So the near flow sensor helps with the flow trigger to allow the baby to take a breath from the ventilator. So for the patient, they might prefer neonatal because they've got that flow sensor that's very close to the ET tube. But for the people looking after the patient, the near flow sensor can be a bit temperamental. It can get on your nerves and it can make the ventilator alarm a fair bit. So therefore, some of the staff that are left looking after the baby necessarily won't like it. So you've got those pros and cons to sort of like examine. Then you've got to decide on what ventilatory strategy you're going to use. So this is a child that's just had an operation, so it's quite possible you might be able to wean him and wake him up very quickly. In which case, yes, you want a synchronous mode, which will rapidly go to a spontaneous mode, so therefore you can then get the ET tube out. But it might be he was sick before he came into hospital, did have a lot of fluid, and therefore you're not going to be able to wean and wake him, and therefore you have some other choices to make. You need to think what sort of ventilatory contribution you're getting from the patient, and obviously if it's a wean and wake, you would expect that they're going to breathe very quickly, and therefore will benefit from a synchronous spontaneous mode. Or it might be they're sick and they need to stay asleep a lot longer, in which case you wouldn't necessarily think in those terms. And also you need to look at your unit experience as well. So what will the nurses and the other doctors expect you to put them on? So if our unit experiences with BiPAP or SIMV or CPAP pressure support, and those would be the modes you would normally expect to put the patient on. So from here, we're going to go over to the V500 Infinity ventilator, and we'll be looking at the simulator and setting up this child on the ventilator. Okay, people, when child comes back from theatre, several things will be on your mind and lots of things will be happening at the same time, all of which you need to keep your eye on. So a bit tricky, but you'll get used to it over time. So one of the first things you need to decide is what's happening first. Are you going to leave the patient on the bed on which he's arrived on and take handover while he's still on the transport vent? or whether it's all still being handbagged in by the anaesthetist, or whether or not you want to transfer him over and connect him to the vent as soon as he comes in, and then you take your hand over. And what you'll find is you'll get a mixture of both. Retrieval teams tend to leave the patient on their system, hand over, and then move the patient over, whereas theatre teams would like to move the patient over, get him on the vent, and hand over after that. But either way, you should be ready for both, or sometimes, or you may decide, depending on the patient's condition, what would be best for the patient. Either way, you would come and you would meet a ventilator that looks a little something like this. The information that's important for you is: what was the intubation like? What size tube is it? Is it cuffed, uncuffed? Is there a leak? How easy was the child to ventilate during the procedure? And did they encounter any troubles? How much fluid did the child have beforehand? How much fluid did the child have in theatre? And this child, we presume, had 40 per kilo before went to theatre, and had another 40 per kilo in theatre. And based on that, we think that the child's had more than its blood volume in a very short space of time of fluid. So therefore, might not be a wean and wake. You'd also want to know what drugs the anaesthetist has given during theatre, and when last he had anything that was sedating or muscle relaxing. And then you'd want to see the general condition of the child. And based on that, you'd be looking to put the child on a ventilator. The last question you'd ask the anaesthetist or the surgeon is whether or not there was a plan for the child to be extubated quickly, or whether or not there was an expectation he'd need ventilating for a period of time. Either way, this 10-kilo baby, in my opinion, given that story, would not extubate quickly, and therefore I'd be setting him up to get on the ventilator pretty sharpish. At the moment, I can see it's set up for an adult. I would need to change that, so I would go straight to new pediatric patient and then click accept. I would then try and put the patient's weight in, and we said that the weight was 10 kilos, and 10 kilos equates to 77 centimeters. In real life, the ventilator does update as you're turning, so you don't need to guess beforehand and then take it from there. So then I've put the weight in, I look at the ventilation, I look at the mode. It's ventilate, it's volume control, assist control. I don't want that, so I am going to change it. So I'm going to go, so you could go to BiPAP, which is absolutely fine. So, and then I would check the settings. I would ask the anaesthetist what they were ventilating at. Said they were ventilating at 20/5, and with that the patient had excellent gas exchange. I would do the same. I think that high time is correct for that patient's age. That's a reasonable rate, but the nurses do not like numbers that don't end in 5 or 0. So for that reason, and that reason alone, I would change it. The slope, or the time it takes for the breath to get to its maximum pressure, which is 20, is 0.2 seconds, and I think that's absolutely fine. But I am going to change the pressure support and give the patient some pressure support to be equal to the amount of the inspiratory breath. So pressure support, which we are going to talk about in a video or so later, and I would add that now, although I'm not expecting him to breathe, but at some point he will wake up and breathe, and if he wakes up and breathes, and I've set this already, he won't be upset and won't become asynchronous, and he can get hit the breaths that aren't mandatory. He can get those breaths supported as well. So this would be the setting that I would start with if I was going to go with pressure, and I would definitely go with pressure if there was a leak around the tube. So that would be fine. If you wanted to go with volume, you would need to go into volume controlled SIMV, click accept. Then you would need to see whether you accept these tidal volumes. You might need more oxygen, and you might have needed a bit more oxygen on BiPAP as well. But that you would have taken your cue from the anaesthetist. This is your tidal volume. Again, the eye time would remain the same. The flow I would not adjust, and we'll discuss that in another video. The respiratory rate remains 30, the PEEP remains the same, and he's still got the pressure support of 15. Now, if you're going to a volume method, you have to include Autoflow, and we would need to switch that on. We would keep the slope the same, but Autoflow is a way of guaranteeing the volume and delivering a volume breath in a pressure mode, but delivering that breath at the lowest possible pressure. So we are going to discuss Autoflow in a following video. However, you need to understand that anytime you set a volume mode, always go into additional settings and put Autoflow on. The other thing you always need to see is whether or not the trigger is appropriately set. If you've put the weight in, that's an appropriate trigger. So children either get a trigger of 1 litre per minute or 2 litres per minute, and this is 1 for a small child. That's perfectly acceptable. So now we're happy with all those. We then go and look at the alarm limits just in case, and these were set up using the patient's weight, which is fine. His peak pressure is 20, so the PIP is 20, so therefore the maximum pressure is 30. He's well within those realms, and we'll see what kind of tidal volume he'll get when we start ventilating. Then we'll know whether or not he's got the right sort of tidal volume. So we've checked the vent settings, we've checked the alarms, and therefore this child should now be ready to go. So either BiPAP or SIMV would be fine. So we click start, and then we've started ventilation. So at the moment he's on volume control SIMV. You check and make sure that we've got good going curves with these loops. These are all blue in colour. If they're grey in colour, it means that the patient has triggered them. So once we've started that, we now go and look at the patient. We make sure that he looks comfortable. We make sure that he's got decent chest rise. We then notice whether or not he's got a leak or not, that the tube's in the right kind of like position. Then after that, we then look at the monitor and we see what sats have we got, what's the end tidal CO2 doing, and then within 20 minutes we'll get a gas. We'd also need to get a chest x-ray just to see where the tube is, and obviously we would need routine bloods as well. So that's kind of like a rapid run through of what we would do when we were setting up a child on the ventilator as he comes into the unit. So thank you guys, that's all I've got for you today. So in summary, we've looked at the ventilation types, we've looked at the ventilation journey, and we've looked at factors determining the start settings using a brief simulation using a little V500 simulator. To take this opportunity to remind you to try and watch this ventilation video from Open Paediatrics. It's very good and talks all about a lot of the things I've said today in more detail. So I'll catch you on the next one. Until then, stay safe.